So we'll start the discussion. First question. It is a burns question. Questions are: determine the degree of burns as shown in this picture. Classification of burns based on depth. Name 3 characteristics of burns to suspect child abuse or non-accidental trauma. Then a IV fluid order. How much is it? Please unmute and answer. How much is it? 25%.
2005.
2.5 liter.
2.5 liter and plus maintenance.
Okay. How did you write the orders?
And,
First 8 hours 50%, next 16 hours 50%.
Another 50%.
Yeah. Is it a glucose containing fluid or what fluid did you add?
NSR.
No, you have to write an IV fluid order. So you should not write NS or RL. You should be writing an actual order which we write.
We should write RL, I think.
RL, ma'am.
RL only, ma'am.
Mm-hmm. Then 8-year-old child with 50% on inotropes. Which drug will be your choice for pain relief? What will you choose? The child is not stable. The child is on inotropes.
Opioid.
Yeah, opioids, you have to mention which one. That is why it's specifically asked.
Ketamine.
Ketamine, you have to give it as an infusion. Yeah, fentanyl is preferred in a child who is not hemodynamically stable. So, first question, determine the degree of burns. 1 second, Okay. I have to stop sharing 1 second. Yeah, is it visible now?
Yes, ma'am.
Okay. So the degree of burns is it is 3rd degree. Why? There is no edema. The wound is looking leathery. And classification of burns based on depth. I will show the image. Now, 3 characteristics which we will suspect, where we will suspect child abuse or non-accidental trauma is, one thing in history is inconsistent history. They will be telling the child got burned from the front and there will be burns on the back side where it is not physically possible for the accident to cause the burn. Then as the characteristics of the burn itself, inconsistent history, sharply demarcated edge in a distinct shape of an object, for example, like an iron box or a small circular burns matching a cigarette or cigar tip, and burns on the perineal area matching a dip in pattern. For example, the child is dipped in scalding water, or sometimes extremities, hands and feet. If all 4 extremities are burned, it is most probably a non-accidental trauma, especially if it is sharply demarcated edge. So the fluid question answer is 1250 ml over 8 hours, then 1250 ml over 16 hours. So regarding maintenance fluid, this child should be put on maintenance fluids too. And if the child is less than 5 years, you have to include a source of glucose. The depth image. So the first one is superficial thickness, 1st degree. There only the epidermis is involved and it will be painful, very much painful. And it does not blister and there won't be any scars. Then partial thickness burns. So there are 2 types. We can divide as 2 types. Superficial thickness. which do not require surgery, but these burns will have blisters and they will scar and they'll be more painful. So they will not reach the dermis. It is only in the superficial epidermis and just the beginning of the just above the dermis. And these will have fluid also in them, and the partial or intermediate thickness second degree which reaches up to dermis, usually the pain will be less and these will definitely form scars. Some of these will require some debridement. And full thickness or third degree, there the entire epidermis and dermis is involved and there is no edema and there is leathery consistency. The burn is usually, the scald or the burn is usually dry and there is no sensation because the entire sensation part is gone. And there will be definitely scarring, and if not properly managed, even if properly managed also, there will be contractures. And this full thickness burns usually need a grafting, skin grafting. In the third image and the full thickness, the chance of infection is extremely high. Then the fourth degree is there where the bone, muscle or tendons are exposed, and usually it is a very severe burn and definitely skin grafting is needed, sometimes with the flap. Muscle flap is needed to cover the burn part. So modified Parkland's 4 ml per percentage total body surface area of burn. That is only the severe burned areas. We should not take the first degree burned areas. So if there is no blister, if there is only erythema and no blisters and no features of a partial thickness burn, then those areas should not be considered for calculating this total burn surface area. And plus normal maintenance fluid for 24 hours. So the replacement fluid is preferred is RL and the normal maintenance fluid is our 0.9 with or without sugars. In burns, one complication is hyperglycemia. So the addition of glucose containing fluid will depend on whether this child has reached that hyperglycemia stage or not. In less than 5-year age children, we will always start with a maintenance fluid of glucose, and according to the hyperglycemia or not, we will titrate it. So half of the fluid is given over the first 8 hours and the remaining half over the next 16 hours. But mind you, we are calculating the 24 hours from the time of the burn. So if the child is presenting to you after 4 hours, the 4 hours, initial 4 hours is also included in the 24 hours. Urine output should be maintained 1 to 2 ml per kg per hour for children who are younger, for less than 30 kg, and 0.5 to 1 ml per kg per hour for older children. If the urine output is less than this, the child is already in trouble. And younger children always they need extra. Sometimes they will need more than this calculated fluid. So that is why. Pardon?
The same thing last time we just did. What?
I'm not able to mute this person. I'm going to put him in the waiting room. Okay. So, so urine output is a better measure to calculate and give the fluids, especially in children who are less than 5 years or less than 30 kg. The fluid needs might be more than what we calculate with this formula. And when we are monitoring heart rate and metabolic acidosis, these are the main indications which will tell us if the fluid resuscitation is adequate or not. But this heart rate, one issue is if the child is in pain, the heart rate will be high. So we have to give adequate analgesia during the initial hours. It is very important because the only two things which are reliable for us is an increase in heart rate and metabolic acidosis. Even if there is a slight metabolic acidosis coming up, we should think that the fluid resuscitation is inadequate. So always keep the urine output, we have to calculate per hour. Per hour urine output and heart rate we have to keep monitoring and check for metabolic acidosis intermittently. Then the fifth question, the child with 50% burns who is not stable, that child we will prefer fentanyl, not morphine. So fentanyl when the child is hemodynamically unstable. And for all the other children, for routine wound care, the moderate and severe burns, we will give rescue morphine. That is, we will not give the pain medication after the pain has started, we will give before. So for minor burns, we can give paracetamol or NSAIDs with or without morphine rescue. Moderate might need morphine rescue before dressing change. And initial days, the acetaminophen or with NSAID, it should be given round the clock. This is burns, it is very painful condition. So it is very important that we give adequate analgesia. And in moderate and severe burns, the morphine should be given before the wound dressing or before the child is mobilized, because otherwise the analgesia requirement will go up very high. Okay, second question, 2-year-old child, what is this? With inability to use the right arm since morning, he was playing with elder sister. Well, child refuses to move the arm, not using it.
Pulled elbow.
Pulled elbow. Name the ligament.
Annular ligament.
Yeah. Investigation of choice.
USG.
If the clinical history is there, if the findings are consistent, we don't need any investigation. So we can write as clinical diagnosis, and if needed, an X-ray or a USG to rule out the other complications, like whether it is a fracture or something. And management steps.
Immobilization, casting, and pain.
Yeah. When do we need casting? Do we cast all the children with a pulled elbow?
First we attempt a closed reduction.
Yeah.
Then
If we are successful, then so first pulled elbow. Yeah. First pulled elbow, if within a few hours we are reducing properly and the child is immediately starting to move the limb, then nothing is needed except for some pain medicines. Just for 1 day or 2 days, we can give paracetamol around the clock because it's a small child. Because we need the child to move the arm. Otherwise, if the child came very late, from morning itself the child is having this, by evening only the child is coming, or we are not able to reduce properly, or this is a recurrent pulled elbow, then we will reduce and put a cast. So it's also called nursemaid's elbow. The ligament is annular ligament. And in less than 5-year-old age, the child is having this typical history of being pulled, whether the child fell or some elder sibling or the mother or father, someone has pulled the child. The child holds the elbow in slight flexion. There is tenderness at that point. Then there is no need of any investigation. If at all, then we can do an X-ray and a USG. Out of those, because of X-ray exposure, usually USG is preferred if it can be done immediately, because we have to reduce immediately. So if USG is not available, we can do an X-ray and see if there is any fracture or it is a complete dislocation. Now, pathophysiology, the mechanism. like we mentioned, it's a longitudinal traction. So what happens is the radial head will slip out. The annular ligament is weak in a child who is less than 5 years age. But if we can put it back immediately, then no issues. After 5 years of age, the ligament will become stronger. So the subluxation is prevented and the distal attachment becomes stronger. And if we take an X-ray, we will see that the elbow joint, the radial head is displaced. It might be subluxated. Sometimes here in this area, we might see this inside this joint area, we might see a small fragment, which might be an intra-articular fracture, or there might be complete dislocation where the radial head might be seen around here. A lateral view also will be needed to diagnose a complete dislocation. And analgesia will be given and manual reduction. So the right side image is USG, that is that small white shadow, it is called synovial hinge. That is between the radius and the humerus. Now, analgesia will be given and manual reduction will be attempted. So it's a closed reduction where the hand is pulled, the forearm is pulled, the arm is fixed, and the forearm is pulled and forcefully either supinated or a hyperpronation is done. If it is a recurrent, cast is applied in flexion and neutral or supination position. If the parents are refusing cast, at least a elbow sling should be given for a recurrent subluxation. And children with recurrent subluxation, follow-up is needed. So this is the annular ligament and hyperpronation, supination, flexion. Here the pulling of the arm is forearm is not shown. One hand is kept like this and we will pull the hand and then do the hyperpronation or supination. Now, differential diagnosis, traumatic causes, it can be a supracondylar or olecranon fracture, or the radial neck itself might be fractured, or lateral condyle rarely. Please be muted. Then sometimes the child might present like this, but it might turn out to be septic arthritis, or it might be a fall and a contusion. So before attempting, we should take a proper history, whether there was anything to suggest a septic arthritis. And sometimes, very rarely, congenital radial head dislocation or forearm synostosis, very rare. Now the next question, 10-year-old girl, Aditi, antenatal, perinatal, unremarkable, 3 kg child at birth, developmentally normal, good scholastic till 2 years ago. Menarche not attained. SMR, Thilarche is there, and systems are NAD. So issue is this preteen, 10-year-old, is tomboyish, prefers to be called Adi, he or his. So she is rejecting her female sex and hates being called she, her, or using a feminine lifestyle. Hangs out with Please stay muted.
Leo.
Hangs out with boys who have accepted him as Adi. So if one person is telling that we have to call them him, we should call him as Adi. So what is the diagnosis here?
दे दिया ठीक है इनको जो है 2-3
Gender
हाँ वो दे
identity
दीजिएगा और
disorder.
एक
Pardon?
Gender identity disorder.
Yeah. Any other names?
थोड़ा हरमाव.
Sorry, I got muted. So yeah, so this is gender dysphoria, or we will call as transgender, gender non-conforming people. So these are the terms given in Nelson itself. Yeah, and diagnosis. So management. What are the gender altering surgeries? This is from a Nelson chapter called Transgender Care. It is chapter 135, page 1027.
Vaginoplasty.
Yeah. Okay, we'll see the answers. So diagnosis, any of these terms can be used. But the blanket term is gender dysphoria. They're not happy with the gender they are assigned or brought up with. So management, the first part is assessment. The assessment should be by a trained, predetermined team of doctors. It should include a pediatrician, a trained psychiatrist, and at least endocrinology team. And the books have mentioned a lot of doctors and social workers and a lot of people who should be included in the team. So you can mention all of them. So the attitude of all these members of the team should be non-judgmental and empathetic stance. And it starts with patient and parent education. So initially, they will tell that this is a situation. It is not a disease. It is just a dysphoria where the person wants to be another sex. So unlike the previous years before, in the past, the main thing was to treat it and try to convince the person to continue in the same gender which the person was born in. But these days, it's not like that. Every person is entitled to whatever sex they want to be in. So initial part, there will be no judgment, there will be no advices. So the initial part will be just management of the stress, the comorbidities, like depression, anxiety. Sometimes there'll be behavior problems. So there'll be some psychotherapy given to the child and the parents for reducing distress. And since the child is very young, 10-year-old, and the child wants to be like this, puberty suppression will be the first choice. So GnRH analogs will be given to suppress the puberty. And if the child is older, so there is some criteria for every nation. So according to the criteria, at least 1 year they have been like this, they want to be the opposite sex, and they know all the effects, like for example, they know about the fertility issues, that if they are changing to the opposite sex and they are going to plan to get rid of their ovaries and uterus, then the fertility is not going to happen at all. So all those kinds of information should be given to the child and the parents, and then a very informed, very detailed discussion should be there, and then only the decision should be taken. So feminizing and masculinizing hormonal therapy, bit of it is reversible, but mostly once it is started, a lot of it is not reversible. So before starting the hormonal therapy, these discussions should be complete and a decision should be reached. Now, the names of the gender altering surgeries: masculinizing chest surgery or breast augmentation, depending on what they want. Like if it is a male going into a female, then breast augmentation, or otherwise masculinizing chest surgery where the breast tissue is removed. Then genital surgeries: phalloplasty, metoidioplasty, and vaginoplasty. Then fertility preservation. So it is the most important aspect of this discussion with the child and the parents. And then as the treatment progresses, some preventive screening. These things you don't have to mention in the exam because it's a new topic. I have just included extra points. So preventive screening like pap smear, mammography, prostate exam, according to the age and sex. Now, next question was the 7-month-old infant who was having receiving inadequate amounts of diluted cow's milk since birth. And now this child has come with failure to thrive and this nail findings. So what are the findings? What is this?
Nails line. Half moon nails.
Knees line.
Differentials? Yeah, you already told the differentials. What caused these lines in the child?
Hypoalbuminemia.
Right. Management? Okay. So these are paired, transverse, homogeneous, smooth bordered lines noted in all the fingers. So the thumb we are not able to see, and the other hands and feet we are not able to see, but this is uniform. And all the finger nails are affected. It is paired, transverse lines which disappear on blanching. So this is Merck's lines. And differentials are Bue's lines and Mee's lines. Merck's lines are homogeneous. So they have smooth borders and they are blanchable. Bue's have transverse indentation. They are actually damaged nails. That area is damaged. Mees are seen in arsenic poisoning, and that is because of deposition, so it doesn't blanch. So that is the difference between these three. Now here in this child is chronic hypoalbuminemia, malnutrition. Sometimes it can occur secondary to any cause of malnutrition or secondary to chemotherapy. So what happens is it occurs secondary to edematous nail bed, causing abnormal nail bed vasculature, resulting in transverse lines that typically disappear. So it is vasculature issue. That is why on blanching it is disappearing. Now, the first image, you can see the damage. The damage is caused by a period of a small period where the cell multiplication stopped. So that is during a hospitalization or a severe infection. And that alone will cause one single transverse line of all the nails. That is Bue's lines. In the third image, the down, that small baby's hand, that is also Bue's starting, but not that much of a indentation is there. It is not damaged as such. But this is not blanching. So this is also a version of Bue's line. Then the upper image, that is arsenic poisoning. So it is not blanching, it is transverse, it is actually white nails. It is not a vascular nail bed thing. It is actually the nail which is white and pink in color. And this is also smooth. There is no indentation like the Bue's. And this is parallel to the lunula. It is growing and depositing like that. So next question, 15-year-old boy. What is this? Cause tremors, dysarthria, blurred vision, recently difficulty, that is dysphagia, and occasional freezing gait. He has deficit in attention, he has coriform movements and athetoid movements.
Wilson's.
Wilson.
Exactly. Yeah. So this is Wilson's disease. So question is findings on the MRI.
Bilateral basal ganglia hyperintensity.
Diagnosis, neurological signs in the order of progression. So half of it I've already given in the question. Sometimes it will be MRI and this image, carefree image will be given. So this is the order: tremor, involuntary movements, dysphagia, dysarthria, and along with dysarthria, lack of coordination or the gait disturbances. Initially, they will describe as a intermittently freezing gait. Intermittently, he will feel like he can't move properly. Then he might develop ataxia and spasticity, dystonic postures, muscle rigidity. And this is obviously neuro-Wilson, and most of the children, 90% will have this carefree. So because it's a very easy question, I haven't included all the details. So this is the MRI where there is the actual that face of giant panda sign. So that is in the brainstem. Slide is not moving. Yeah. So just to mark the, just to show where it is, like the left side one is a marked, labeled normal brain, where the thalamus is shown, the down, the first arrow is the putamen and the second one is the thalamus. So you can see that the color is fine. In the right side one, you can see the hyperintensities. This is T2 image and the hyperintensity in the thalamus and the putamen is visible. So this right side image is the one which I kept with the question. Now this question, what is this?
Ma'am, it can be a systemic onset juvenile idiopathic arthritis or a systemic malignancy.
Okay. So in systemic onset arthritis, juvenile arthritis, where do you expect the findings to be? What scan is this?
PET scan.
PET scan.
Yeah. What is the finding?
Increased uptake in the bilateral femur, tibia, and there is a lung nodule also, I think.
Yeah. So what you thought is right, but that is not the bone. That is the vessels.
Okay.
So the lower limb vessels are involved. That is what it is showing. And the lung, that black arrow is a lung infection. And the white arrow is apparently the esophagus. So there was some irritation or whatever. That is why I told not to consider those two. Because that is just, herring. And the black triangle, that is the, can you see the black triangles? Arm. Those are arm vessels. Is it visible?
Yes, ma'am.
See the cursor? This one. This is the arm vessel, that line. This. So all the blood vessels in the extremities are involved. That is what this PET scan is showing. So this is a child with high-grade fever and generalized malaise, painful legs, and bowel, bloody diarrhea. Bowel is involved. And there is increased respiratory effort. That was because of an infection. This child also had a lung infection. That is that orange thing.
Yes, ma'am.
Pardon?
HUS.
No.
Can be
You
Takayasu.
are thinking right. You are thinking right. But this is not HUS because upper limb vessels are also involved.
Can be Takayasu arteritis.
Yeah, it can be Takayasu. But in Takayasu, will the peripheral vessels be involved or the central ones?
Central ones.
So we will see the aorta involved. Here the aorta is not involved. It is mainly the extremities. CRP is 307. Yes. Oh, I didn't write the ESR. ESR was above 100.
Ma'am, Wagner's or
Ma'am, rheumatic fever.
Rheumatic fever. No. No, the Takayasu, that path is right. What is the next one to think about?
Polyarteritis nodosa.
Yeah. So this is a case report I have directly taken and put from European Journal of Nuclear Medicine. So this is a 9-year-old boy. This is an actual real case. That is why that lung thing and all is there in the picture. So this child had 10 days of fever and the child was quite sick. So they have gone ahead and done a PET scan and they found these vessels involved like this. So these are the vessels. And from the continuity, you can tell that this is not the bone. Knee joint area, you can see, no? It is continuous. So you can tell that this is a vessels. So FDG PET is showing these major arteries are showing this a lot of uptake, and this is polyarteritis nodosa. The child responded to steroids. So this pyrexia of unknown origin is what I meant to put, but we don't have time, so I'll just skip this part. You know the definitions. So at present, if it is at least 8 days, we can take it as a pyrexia of unknown origin, provided we have covered all the history, all the physical examination properly, and the lab work has been done very stepwise. We have done the lab work, then even by 8 days or more, we can take as a pyrexia of unknown origin. But suppose a child is even less than 8 days also, we can take up this child for further investigation. We don't have to wait 3 weeks or 2 weeks like before. Even before 8 days, if we don't find a source and the child is getting sick, we can go with the provisional diagnosis of fever without source and we can start the investigations. So workup preliminary imaging, we will do only a chest x-ray or a ultrasound abdomen, or if we have any suspicion that area, like for example, if we are thinking it is osteomyelitis of some area, we will go ahead with cultures and all. But initially for every other child, imaging, blood urine, only the basic CRP or complete blood count, then urine analysis and cultures. Then if nothing turns up, we will go to more advanced or invasive investigations. We will go for imaging, we will go for immunologic or organ specific workup like liver function or renal function. We might go for further scans, CTs, MRIs. Then nothing turns up, we will again go for more invasive, more expensive investigations like a bone marrow aspiration with biopsy. We will do bone marrow cultures, then a PET scan like this one, and genetic tests, for example, to find the infectious causes like 16-RS rRNA or invasive FNACs or biopsies. We might look for occult abscesses somewhere, all those things. So in Nelson, there are beautiful tables given. Please go through. We can expect something from pyrexia of unknown origin. It can be kept as a ward rounds or ambulatory case also, because initial investigations are OP basis. So they can keep a fever child as ambulatory case too. So this is just basic details regarding PET scan. So fasting is required because this is a glucose-based test. And the main principle is that we are labeling this form, this FD form of glucose, D-glucose, and the tracer is on the glucose. So whichever area is inflamed and is more active, that area will take up the tracer. So that will turn out as positive. So in this child's case, the arteries were taking up all the sugar and they were showing us positive takers. And it is detected using a gamma camera in a setup like a CT itself. Next question. This is a 5-year-old child. What is the answer?
Measles, Kawasaki, Missy.
This child is having fever with rash, and by 3rd day rash is there, and red eyes, running nose and cough. Is it MIC? Is it possible?
Yes.
Yes.
Yeah, but
Yes.
the MIC definition is no other disease should be fitting. Then only we will
Yes.
take MIC as the diagnosis.
Nice.
And MIC usually won't have a runny nose. It can have red eyes and cough. Even cough is possible, but usually runny nose is typical of a viral infection. So what are the important points to ask in the history? Definitely immunization status of the child, contact.
Past history of COVID, vaccination, contact.
Yeah, contact. Then fever rash relationship. That is the most important clenching point in measles. When the rash is starting, the fever will subside if it is another fever with rash, for example, like exanthem subitum. The fever is going to crash and then the rash is going to appear. Pardon? Pardon? Is someone saying something? Sneha? Okay. So suppose the fever is worsening, the fever is increasing in intensity. Once the rash is coming, then it is more in favor of measles. Cough, coryza, and conjunctivitis, it is more in favor of measles. Spread of the rash or the evolution of the rash, and where the rash is starting from the face spreading to the body, or it is appearing first in the body. And once the rash is resolving, whether there is a brawny induration, brawny desquamation or not. So differential diagnosis contains, this is only 3 days of fever, but still KD is in the picture. Dengue, parvovirus, scarlet, and exanthem subitum, even though history, exanthem subitum can be ruled out from the history itself. Now, the virus is measles morbillivirus. Management, investigations, IgM or RT-PCR can be done. Then vitamin E, paracetamol, and avoiding NSAIDs, all those things you already know. And the schedule, MMR or MR vaccine, 9 month, 15 month, and 4 to 6 year. If there is any campaign in between, that should also be given. So this child who is not immunized, that child is given in the history. So definitely you have to write the catch-up for this child. This child needs catch-up immunization, 2 doses, 4 weeks apart. Koplik spots. Now this child, what is this?
Gastrocyst.
Yeah, very simple question. We'll go fast. Complications are hypothermia, dehydration, infection, sepsis, feeding issues, and requirement of TPN and TPN related complications. Now management, silo placement, reduction, manual reduction. Then sometimes there might be necrotic segments. What are the contents? Most common contents? What is outside? Intestine and liver. Liver might be there. Then necrotic segments might have to be removed. So in the long term, short bowel can be a complication, and most of the children will need some stomy, gastrostomy, jejunal or ileostomy. And the table, this is just the difference. Everyone knows, so just skipping that. Congenital anomalies are most common with other congenital anomalies. Yeah. So this is a transvaginal scan. Just in case they are keeping a USG, I've just added this. So that is a baby. That white round thing is a baby, and it is a baby's abdomen, and we can see the defect, and the intestine is out.
Slide's not moving. It's still on the management of measles.
Really?
We can.
What about now?
Oh, moving.
Okay. Is it a USG now?
Yes, ma'am.
Yes.
Okay. So in between there was nothing. It was just this table.
Ma'am, is still not moving. Can you reshare the slides again?
Okay.
There are some of the participants who are also facing the same problem.
Just 1 second. Someone is there in the waiting room still. No, nothing. Okay, is it visible?
Small. Yeah, ma'am.
Is it a USG? Okay. So this is a transvaginal scan where we can see the baby's abdomen. So this white round thing is the baby's abdomen, and that red crosses, those are showing an abdomen defect, and that number 2 which is written there, that yellow thing is the bowel loops, which is outside in the amniotic fluid. And 4 is the umbilical cord. And so the 5 is the baby's stomach, which is inside. Now this child, what is this? Which syndrome? Which syndrome? Yeah, left hemiatrophy of the face. It is asymmetric face, dysplastic ears, and alar nasal. Okay. So which syndrome was it?
Golden heart syndrome.
Yeah, and it comes under this is the limbal dermoid, which is very common in golden hair. And this image, I have just put these images because recently they have kept a lot of Wikipedia images. So these are Wikipedia images. So just for you to be familiar with the Wikipedia images, I have just kept them. This is the preauricular tag image, which they have put in there. And the 4 dysmorphic features which are evident in that picture is microtia, microphthalmia, hemifacial asymmetry, or you can mention as dysplasia, and mandibular hyperplasia. So it is golden hair, the triad, it's epibulbar dermoid, which we saw, accessory auricular appendages or microtia, and oral fistula. Inheritance is sporadic. 4 eye abnormalities are microphthalmia, epibulbar dermoids or limbal dermoids, lipodermoids, or coloboma. Now, this is often mentioned as a spectrum, oculo-auriculo-vertebral spectrum. So, most of the children will have some vertebral component. So what is the vertebral anomaly? Spina bifida can be there, or hemivertebrae, butterfly, fused and hypoplastic vertebrae are the vertebral anomalies. And some of the children might have some skull anomalies also. There can be craniosynostosis, for example. And the OAVS spectrum, usually the main division is the left side one, golden hair, hemifacial microsomia, and oculo-auricular vertebral disorder. This is disorder is a milder form, and the actual spectrum, the other diseases are often severe. And the right side one I got from another source, but few of them are very mild forms. So usually those are not mentioned as subdivisions. Now last one, 8-year-old child with this. What is this? So there is a correction in the question. This child is also uttering bad words.
Tourette syndrome.
Yeah. So what are the components?
Motor tic,
tics.
vocal tic, palilalia, coprolalia.
Okay. So this is 8-year-old boy and he is having the symptoms for 14 months. So one criteria to diagnose Tourette is the symptom should be there for more than 1 year. He says that he can feel the movements. That is called sensory. That is called premonitory urges. Premonitory urges. Sensory phenomena. So the criteria needs a lot of motor tics, more than 2 motor tics. It can be simple motor tics or complex motor tics. This child in the video is having complex motor tics, and there can be 1 vocal tic. 1 is enough. So it can be palilalia, which is repeating on words, or echolalia and sensory phenomena, and it can be suppressed. So if the child is focused, doing some activity where the child is very much interested, the child may not have it. or during sleep it might be suppressed. And this Tourette, the tics are suggestible and it worsens with anxiety, depression or stress, and it's more in the evening. So management wise, initial thing is screening. So all these screening tools are not used in our country. This is outside. I have taken from Nelson, but it is not used here much. What we use is, we will ask the parent to look at the timing, the triggers and the features. We will ask for the parent to record it and bring. And assessment wise, we are using the third one, YGTSS, the Yale's one. So all these are given in Nelson, the chapter 37. Investigation wise, a CBC, LFT, RFT, a thyroid profile and ferritin is done. And EEG, MRI is not indicated. So for this child, an MRI is planned, but if the child is not having any other issues and is fitting into this motor and vocal tics, then an EEG or an MRI is not needed, but a psych evaluation is necessary because there might be some behavioral problems or stress or anxiety, depression, comorbidities will be there along with this. And this is copy paste from Nelson. This is a diagnostic criteria. So multiple motor and one or more vocal tics. Vocal tic can be simple. There can be just a whistling kind of sound, or there can be complex vocal tics like words. So they can wax and wane, but at least 1 year should be there, and onset is before 18 years. And it is not physiologic. For example, not due to a drug or another medical condition. And management wise, psychoeducation of the parents and the child. Habit reversal therapy, it is explained in detail in Nelson, and comprehensive behavioral interventions for tics. Antipsychotics, for example, the first generation antipsychotics are useful. Alpha agonists like clonidine. Then very important is the management of comorbidities like anxiety, depression. Okay. Thank you. Any doubts?
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
Yeah.
Thank
It
you,
was
ma'am.
easy to moderate. This is the first time and very early, so I have put mostly easy questions. Yeah. Thank you. Yes, it is all body PET scan. Yeah, no other doubts. Don't need X-ray, right? Thank you.